So I'm Sinéad Murphy, I'm a neurologist in Tallaght and also the clinical lead for the Irish site of the European Reference Network for Rare Neurological Disorders. And so just a word on rare disease, which, as most of you probably know, is defined as a disease that affects less than 1 in 2,000 people, and they are growing at a rapid rate. We now have over 10,000 individual rare diseases described, and 50% of all rare disease is neurological, so very important for neurologists to know about these, and 90% of all neuromuscular diseases are rare, so really important for the people in the audience. And even though each individual rare disease might only affect a small number of people, cumulatively they affect about 6% of the population. And it's estimated, as you heard from the Minister, that about 300,000 people in Ireland are living with rare disease. And this should be very important for health policymakers and funders, because for conditions that affect only 6% of the population, they account for half of all healthcare utilisation. So 50% of costs in healthcare go towards rare disease, because people with rare disease attend hospital more often, they have more complex treatments and diagnostics, and so this should be very relevant. So moving on to neuromuscular disease, we do have some data from Ireland, and this paper actually from Orla and colleagues a few years ago looked at the epidemiology of neuromuscular disease in Ireland, and you'll see this is a very long list, and there were more listed that are not, I couldn't fit on the slide, but you'll see that each of these diseases only affects really a handful of people, mostly in Ireland, so they're single and double digits. So it's very difficult to do research on a condition when you only have a small number of people affected. And most neuromuscular diseases, of course, are diagnosed by neurologists, but neurologists are actually a bit of a rare breed in Ireland too. We have the lowest number of neurologists per population in the EU. We have 1.3 per 100,000, compared to the EU average of 9 per 100,000, and compared to countries like Georgia, who have 20 times the number of neurologists. So it should be no surprise that we have extremely long waiting lists. There are more than 20,000 people waiting to see a neurologist for the first time, and that has been the same since 2018. It is not getting any better. That's partly because Ireland is a very rapidly growing country. We're the third fastest population growth in the EU, and we have seen, for that and lots of other reasons, a quadrupling of neurology referrals in the last 5 years. And neurological disease is now the leading cause of disability worldwide, and it affects more than 1 in 3 people. And with such long waiting lists, it should be no surprise to you that we have very long delays in making diagnoses. So in all neurological conditions, in fact, but particularly in neuromuscular conditions, which can be more complex and sometimes more difficult to diagnose, this particular paper showed a diagnostic delay of more than 4 years from when the patient first presented. So in Ireland, we have 27 Model 3 and 4 hospitals and 64 neurologists. And you can see the ones in red, those hospitals have a neurology service full-time. The ones in yellow have an outreach service. That means a neurologist goes there 1 day a week usually. And then there are several hospitals where there is no neurology service at all. So you can see that there are very large parts of the country, especially in the middle, really, that have very limited access to neurology. So that's very relevant for people that have neuromuscular and other neurological diseases. And neurophysiology, which some of you will have had, is the test with the little electrodes and needles. That's really important for diagnosing neuromuscular conditions, but that's only available in 7 hospitals around Ireland, mostly based in Dublin, Cork and Galway. And moving even rarer, there's only a handful of neuromuscular clinics, again, Dublin, Cork and Galway. So it's very hard for people with neuromuscular disease to see a neuromuscular specialist. And we looked at this in my clinic recently, and I think you can see that a fifth of all new patients are traveling more than 200 kilometers to come to the clinic to get an opinion. So that's how, it's very difficult for people with mobility challenges to travel, but they are traveling very long distances and they're waiting a long time. And there's a good deal of patients who are being referred for second opinions. 40% of people are coming for a second opinion from another neurology service. So it just really highlights the need for more neuromuscular specialists in Ireland, I would argue. So I was going to talk about the cycle of drug development for genetic diseases. So with any disease, you start off with a patient. The patient is described. We describe the phenotype, which means the symptoms and signs that a patient has. And once you have a collection of patients that we think have the same condition, you can go into the lab and try and discover the gene that causes that condition. And once you've discovered a gene, then you're able to diagnose more patients with the condition, and you realize usually that it's not as straightforward as you thought, and there's a more complex phenotype that can occur. And then a lot of work goes into figuring out what the function of that gene and that protein are. And you have to try and understand how a problem with that gene and that protein cause disease, because if you don't understand how the disease happens, it's very hard to target a treatment at it. And then once you have a treatment, finally, after you jump all through the hoops of clinical trials and so on, you can give it to the patient. So that's a very basic description of the cycle. And over the last 40 years, we've seen very, very major advances in gene discovery. So back in the 80s and 90s, we were discovering, a handful of genes a year. And now we're discovering 200 and 300 new genes every year that cause disease. So massive advances. And this paper on the right, this is a list of all the genes that can cause neuromuscular disease. And there are more than 800 different genes on this list. And every year they add another 10, 20, 30 genes to that list, because it's just our knowledge is expanding all the time. And as our understanding of the genetics increases, so does our ability to find treatments. So this graph on the left shows new clinical trials for gene therapies. And you can see back in the 90s, there were maybe 50 or 60 gene trials starting a year. And we're now up at over 200 new clinical trials starting each year for genetic diseases with gene therapy. Now, not all of those treatments reach the patient because some of them don't work, but it's very, very promising. So I thought I would use one particular disease as an example. This is a condition that I see a lot of patients with, hereditary transthyretin amyloidosis. And this was first described in the neurology literature in 1952, describing a lady who was 37 they had first met in 1939. So like a really long time to get to the description of the patients. But basically they described that this condition started with weakness in the legs, spread up to the arms, then they got impairment of pain and temperature and pain in the legs with diarrhea and vomiting and sphincter and sexual disturbance. And then patients would die from this condition. And it was very prevalent in this particular region in Porto, which is a fishing village in Portugal. And it took 26 years before they discovered the gene that caused that condition. And once the gene was described, it was possible to diagnose people around the world. And it became clear that this was not just a disease of Portugal, it was a disease of everywhere, including Ireland. And in fact, in northwest Donegal, 1 in 80 adults carry a mutation in this gene and are at risk of developing this terminal neuromuscular condition. And we now have a very good understanding of how this disease happens. The protein is produced by the liver. So then we move on to treatments, and someone thought in 1990, what about if we remove the liver? Maybe that will help. And it did. That was the first ever treatment for this condition. By doing a liver transplant, that made a real difference to the outcomes. And then since then, there have been many different treatments that have come. Really since 2018, I suppose, was the big change, and all of those treatments now are available and reimbursed in Ireland for this condition. We also have many trials ongoing looking at CRISPR-Cas9 gene editing. So this is a gene editing that gets into the liver cells and switches off the gene and stops the liver producing the abnormal protein at all. And we also have trials of treatments at other parts of the pathway trying to remove amyloid from the tissue. So once you understand how that protein causes the disease, you can attack it at lots of different parts along the pathway. And all of these treatments have been shown to prolong survival, improve quality of life, reduce hospitalizations, and we see that the earlier people get on treatment, the better they do. So it's really important to diagnose people early and get them on treatment early. And we're now moving from treating people that already have the disease to treating people before they get the disease. So we are now moving into a trial of pre-symptomatic mutation carriers. So you identify families, you identify children who have the mutation but don't yet have disease, and that trial has started. We recruited our first patient in Ireland a few weeks ago. So there's really massive advances in a very short number of years. Now, one of the challenges is that once you have a treatment, the landscape of that disease changes. So patients survive longer, and you start to see that they develop symptoms that you never knew would happen in that condition before. So in the case of transthyretin amyloidosis, we now see that they get brain disease if they live longer. And that is a challenge because the treatments that we have don't get into the brain. So with each treatment, you see there are new challenges come. But there are lots of other things that happen. Once you have a treatment, it's really important not to miss that diagnosis. So you have to raise awareness in the medical community and in the community at large so that people think of it so that they can be diagnosed, because a doctor can't diagnose a condition that they've never heard of. We also know the impact of early treatment. So that means we need to diagnose people really early, and we need to get them on treatment as soon as they're diagnosed. And when there's increasing awareness in families, we see increased presentation to services. So there's more demands on the genetic services, neurology services, cardiology services. And this graph is a graph of the number of patients who've been referred to me in the last number of years. So my first ever patient was referred to me in 2017 with this condition. And then the treatments became available around that time. And you can see year on year, more patients are being referred. So this is a challenge, I suppose, for the hospital service. So when we come back to that cycle, it doesn't end once you have a treatment. Once you have a treatment, actually new challenges appear, and the cycle continues looking at better and other ways of treating that condition. And I'm going to finish up by just saying, aligned with the theme of today's conference title of Connections, collaboration really in rare disease is really, really important. So like I said, we're a site in Tallaght for the Rare Neurological Disease European Reference Network, and you can see on that map of Europe all of the other sites that are involved. So this is a network of clinics around Europe who are interested in rare neurological disease. And by collaborating with those groups in that network, it really allows us to research these diseases in a way that you could not possibly do from a single site or a handful of sites. It allows us to discuss individual patients with other experts from around the world. It offers training and education to our trainees to raise awareness, to write clinical practice guidelines, and really importantly is the rare disease registry. So we all of the sites on that graph, on that picture, input patients into or recruit patients into the Rare Neurological Disease Registry, and that is already showing benefits for patients. So just as an example, there's this very rare condition called Polar 3A spastic ataxia, and this particular group in Heidelberg in Germany emailed around all of the people in the network to say, do you have any patients with this particular condition, with this particular mutation? And in Tallaght, we have 4 patients. And you can never do anything research-wise with 4 patients in a single site. But in the network, there were 85 patients from 21 sites. And all of those patients are now recruited into a natural history study. And alongside that, the One Mutation, One Medicine group, 1M they call themselves, who are another group of individuals from sites in the European Reference Network, are developing an antisense oligonucleotide, which is a genetic therapy targeting that specific gene mutation. And the idea is that when that therapy is developed, that the patients in the natural history study will be able to roll into a trial of treatment. So the registry is already having benefits for patients with very rare diseases. And I should say really that this should not be seen as research. It is research, but this should be part of clinical practice for rare disease particularly. And we're trying to build it into our routine clinical practice in the clinic, because it's only by making it happen all the time for every patient that we can really make advances in these diseases. So I'll finish there just by thanking my colleagues.